Can we start, Dr. Manoj? It is 7:30.
Yes, Ravi sir, let's start.
Yeah. Good evening, everybody. Good evening, good morning, everybody. A warm welcome to the prestigious Learn from the Legends series organized by Indian Academy of Pediatrics Neonatology Chapter, National Neonatology Forum Kerala, and National Neonatology Forum Thrissur and IAP Thrissur. This is a very popular international webinar series in which we try to imbibe the maximum number of veterans from all over the globe for an update in the current developments in the field of neonatology. Today, I have great pleasure to introduce the topic. It is the lessons from LOA for the management of periviable fetus. And the specific topic is what are the limits of viability for extremely preterm infants. And to talk to us on this very important topic, we have none other than Professor Edward Bell from the University of Iowa, Family Children's Hospital, USA. A warm welcome to you, sir. And to moderate this session, we have two eminent neonatologists from India. I am glad to welcome Dr. George Na, Professor and Head of the Department of Pediatrics, Gandhi Medical College, Bhopal.
Good evening, all.
Good evening. And Dr. Pradeep Dabata, Professor, Division of Neonatology, Department of Pediatrics, VMMC, and Safdarjung Hospital, New Delhi.
Thank you, sir. Thank you.
A warm welcome to both of you. Manoj, please take over the further proceedings. Thank you.
Hello, everyone. Good morning, good afternoon, or good evening, depending on whichever part of the globe you are in now. Hearty welcome to today's session of Learn from the Legends. Friends, Iowa in US and Japan continue to have amazing survival rates for periviable fetuses. What are the lessons we could learn from them today from Iowa regarding the management of extreme preterm neonates in our clinical practice? We have the privilege to learn from the horse's mouth today. We have with us none other than Professor Edward Bell from Iowa University. To introduce Professor Bell, Dr. Bell received his MD from Columbia University. He completed his residency in pediatrics at Columbia University and fellowships in neonatology at McMaster University and Brown University. He is the professor of pediatrics at University of Iowa, and throughout his career, he has conducted clinical and translational research related to care of prematurely born infants. We all know that. He is the principal investigator of University of Iowa Center in the NICHD Neonatal Research Network. Dr. Bell and his colleagues at the University of Iowa have been leaders in the management of infants near the limits of viability. We continue to get amazed with the kind of outcomes they report. The outcomes for infants at 22 and 23 weeks gestation are among the best in the world. We all know that. There are a lot of lessons to learn from them. Professor Bell has developed and maintains a very unique registry which no one else does, the tiniest babies registry, a web-based registry of surviving infants who weighs less than 400 grams at birth. We live in a world of challenges. However, if you need to progress, we need something to look forward to. And today we have a legend who can tell us what to look forward to. Without wasting any more time, ladies and gentlemen, I have great pleasure in introducing the legend of the day, Professor Edward F. Bell. Over to you, Professor.
Thank you very much for your kind introduction. I thank the organizers for inviting me to participate in this great international webinar series. I'm honored to be considered worthy of participating in the Learn from the Legends series. I'm going to speak today about the limits of viability for extremely preterm infants. I will talk about the limits both in terms of gestational age and birth weight. I have no conflicts of interest to declare. Some of my slides were provided by or created in partnership with Dr. Matthew Rashavi. Here you can see the University of Iowa Children's Hospital. The hospital opened in 2017. And just across the street, you can see the university's American football stadium. This juxtaposition, as it turned out, was quite fortuitous and quite important because it led to the creation of one of the best traditions in American college football, the Iowa Wave. At the end of the first quarter in every home football match at the university, all of the 70,000 fans, the players, the coaches from both teams, and the officials turn and wave to the children in the hospital. The children and their parents wave back to the fans. This is what the view looks like from the hospital, where the children and their parents are waving. This is a very inspiring and moving experience. Here you can see our head football coach, Kirk Ferentz, and some of the players waving to the children. And here's what this spectacle looks like at night when the fans wave with their phones turned on to the flashlight mode. Kirk Ferentz and his wife Mary have been very supportive of the Children's Hospital. They have had 2 grandchildren who were prematurely born infants who were patients in our neonatal intensive care unit. And Kirk and Mary have donated $1 million in support of neonatal research. If you want to see more about the Iowa Wave, there's a very nice 6-minute video that was produced by ESPN, the American Sports Network, that you can find just by Googling Iowa Wave. In 1973, my first year of residency, we did not intubate most 28-week infants because to do so was considered futile. These infants were most likely to die regardless of whether we intervened on their behalf. In the year 2022, we don't intubate most 28-week infants because to do so is usually unnecessary. Over the arc of my career, we've seen such amazing transformation and progress in neonatal care. How did we get to here from there? If I try to reduce this to a few basic elements, I come down to the 3 A's: antenatal glucocorticoids, artificial surfactant, and active or affirmative care. I've been working in this field for more than 40 years. In the 1970s, the gestational age limit of viability was around 27 weeks. And over each decade of my career, the gestational age limit of viability has decreased by about 1 week. None of us ever thought we would see survival of 22-week babies. And yet here we are in the year 2022, where we are now seeing frequent survival of 22-week babies. I did an interview with the New York Times 20 years ago when I said we can't possibly see survival advance earlier than 24 weeks because the physical distance from the alveolus to the capillary bed is too great, and we won't be able to see exchange of oxygen and carbon dioxide across this physical barrier. And yet here we are. How do we know when it's time to start treating younger babies? The first 22-week baby we admitted to our NICU was in 1999. I was called back to speak to the mother who requested to speak to a neonatologist. This in and of itself is unusual because most pregnant women have never even heard of a neonatologist. So I went back to tell her that we were sorry, but we wouldn't be admitting her baby because there was nothing we could do for a 22-week baby, and her child would not be able to survive even if we tried to intervene. But she said to me, "Dr. Bell, you may not remember me, but we had the same conversation 5 years ago when my 23-week daughter was born, and she survived and is doing well." And so it was very hard then to deny admitting her 22-week baby who was born a day or two later. Her baby did not survive, but a year later, in the year 2000, we had our first 22-week survivor. So from time to time, we have to push the wall and see if it will move. So I'm going to talk with you about the changing landscape and where we are in the year 2022 with the care and outcomes of 22 and 23-week babies. If you're looking for tips of how to manage these babies, you're going to be disappointed because I'm not going to talk about that today. What is happening nowadays with 22-week infants? Recent publications have shown continued variation in treatment rate and outcome by hospital and country of birth. Rates of active treatment and survival are increasing. We have very few outcome data for these babies because we haven't been treating them for very long, but the outcome data we have at 2 and 3 years show handicap rates that are similar to 23 and 24-week infants. This figure is taken from a paper published by Matt Rashavi in 2015. On the vertical axis is the proportion of infants receiving active treatment at 24 different hospitals in the NIH Neonatal Research Network. Each hospital is indicated by a small black square. You can see at 24 weeks, the vast majority of infants were receiving active treatment at all hospitals. The same was true at 25 and 26 weeks. Before 22 weeks, there were almost no infants being actively treated at any hospital. But the gray zone was at 22 and 23 weeks, where there was a great variation in the active treatment rate from hospital to hospital. At 22 weeks, for example, there were 4 hospitals where no 22-week infants were actively treated, and 6 hospitals where all 22-week infants were actively treated, although the numbers were small, as you can see from the large error bars. And in between, there were hospitals where there were quite variable rates of active treatment. The same was true at 23 weeks, where all hospitals treated at least some babies, and some hospitals treated all babies. So to summarize, we have no reports of survival at 20 weeks. There are isolated case reports of survival at 21 weeks, and I'll talk about several of those babies later. The majority of infants survive in most NICUs in affluent countries at 24 weeks. And the area that we're going to talk about mostly is the gray zone of 22 and 23 weeks. In the United States in 2018, there were only about 4,000 live births at 22 and 23 weeks. This is about 1 in 1,000 births, which is similar in incidence to fetal alcohol syndrome and Down syndrome. So it's not common. However, these births account for 1 in 7 infant deaths in the US. Here you can see the decreasing mortality of extremely preterm infants born in Japan. I call your attention to the top line, which is the 22-week infants. And from 2003 to 2018, the mortality rate has fallen from about 73% to 40%. These are the outcomes in Sweden. Here the vertical axis has been flipped and now shows survival. And the bottom line is the 22-week infants. And the survival rate has increased from 25% in 2004 to 55% in 2016. In the United States, this figure shows the rates of active treatment and survival for infants born at 22 weeks in Vermont Oxford network, which represents about 85% of preterm infants in the US. You can see the active treatment rate was fairly steady from 26 to 30% for the years 2007 through 2014, but then began to increase in 2015 and is now over 50%. The survival rate, including those who were actively treated and those who were not treated, held steady between 5 and 8% from 2007 to 2014, and then began to increase in 2015 and was up to 17% in 2019. So in 2019 in the US, the majority of 22-week infants were actively treated. The survival for all infants, including those not treated, was 17%. Those not treated, the survival, of course, was 0%. And for those actively treated, it was 29%. And this figure is derived by dividing 17% by 58%. What's the evidence for the efficacy of antenatal corticosteroids before 24 weeks? Until recently, corticosteroids were not given to women who were likely to deliver before 24 weeks in the US because the American College of Obstetricians and Gynecologists did not recommend this practice. However, here's the result of a meta-analysis published in 2016 that included 3,600 infants. And you can see that for all infants under 24 weeks, the risk of mortality was reduced significantly by giving antenatal corticosteroids. The odds ratio overall was 0.48, which means a 52% reduction in mortality. If we look just at infants of 22 weeks, the numbers are rather small, and the odds ratio was 0.66 or 34% reduction in mortality, which did not quite reach significance. However, this meta-analysis did not include the 7,000 infants reported by Eric et al. 2 years later. And if it had included these, it would have certainly reached significance. For 23-week infants, the PARC meta-analysis did reach significance. Last year, the American College of Obstetricians and Gynecologists issued a practice advisory suggesting that antenatal corticosteroids may be considered at 22 weeks if neonatal resuscitation is planned. The Swedish consensus guidelines have recommended antenatal steroids be considered at 22 weeks since 2016. The British Association of Perinatal Medicine recommends that resuscitation be considered for babies from 22 weeks on. This paper that was published just a few weeks ago looked at the association of antenatal steroid exposure at 21 or 22 weeks with neonatal survival and survival without morbidities for infants born at 22 and 23 weeks. There were 431 infants. Infants born after a complete steroid course were twice as likely to have survived to discharge and 2.7 times as likely to have survived without major morbidity. These findings support the recommendations for antenatal steroids for infants who will be actively treated at 22 weeks. This table summarizes some recent survival rates for infants born at 22 weeks. The entire Vermont Oxford network reported 9% of live-born infants at 22 weeks survived, but 29% of those admitted to NICUs survived to discharge during these years. The Japanese Neonatal Research Network reported 46% of live-born 22-week infants survived, and 51% of those admitted to NICUs. The Swedish National Quality Register reported survival of 30% of live-born 22-week babies, and 58% of those admitted to NICUs. And then we have here reports from 4 individual centers with excellent outcomes. The University of Cologne reported survival of 38% of live-born 22-week babies, and 61% of those admitted to NICU. The University of Uppsala reported 52% of live-born infants survived, and that was also 52% of admissions because all live-born 22-week infants were admitted. The University of Iowa reported 64% of live births and 70% of admissions survived. And in a small cohort, Nagano Children's Hospital reported 81% of live-born 22-week infants survived, and 93% of those admitted to the NICU. What about other European countries? In 2014, Gallagher et al. Reported on a survey of practices in European Union countries. Throughout Europe, there was little consensus regarding how active intervention after birth at 22 to 25 weeks is managed, but country was the biggest contributor towards whether or not active care is undertaken at these extremely preterm gestations. Here is a summary by country. I call your attention to this column of 22 and 23 weeks. You can see in yellow the countries that did not offer resuscitation at those gestations in the years of the survey, which is now about 10 years old. and in blue, those that made individual case-by-case decisions, and only Turkey claimed to offer resuscitation routinely at 22 and 23 weeks. So survival rates above 50% for actively treated 22-week infants are now being seen in several national cohorts and for all live births in a few high-performing centers. Active treatment rates at 22 weeks in the Vermont Oxford Network US hospitals doubled between 2015 and 2019 to over 50%, and survival rates at 22 weeks in Vermont Oxford Network have tripled. But, and very importantly, we need to ask, not only are babies surviving, but how are they doing in terms of neurodevelopment? Admittedly, we have very few data available because these infants haven't been surviving for very long, and we have very few reports of 2 or 3 year outcome. The Rashavi paper reported 2-year outcomes of 18 22-week survivors. 39% had no or only mild neurodevelopmental impairment. 28% had moderate impairment, and 33% had severe impairment. The Watkins paper from Iowa reported 2-year outcomes on 17 infants. 55% had no or only mild impairment. 27% had moderate impairment, and 18% had severe impairment. The Japanese have reported 3-year outcomes on a cohort of 77 22-week survivors. 13% had cerebral palsy, 14% had visual impairment, but only 1 was blind. None were reported to have hearing impairment. 46% had cognitive impairment. 44% had developmental quotient below 70, and 58% were said to have no neurodevelopmental impairment. And this very important figure, published by Taylor et al. Last year, shows that neurodevelopmental impairment identified at 2 years can often improve or disappear by 10 years in extremely preterm infants. You can see here that quite a lot of the infants who were found to have moderate to severe impairment at 2 years had no or only mild impairment by 10 years. So we need to keep this important fact in mind as we look at these short-term outcomes, namely at 2 to 3 years. We have absolutely no school age outcome reports for 22 and 23-week infants. Here you can see 2 of our 22-week survivors from Iowa. Now, what about 21 weeks? This is Curtis Means, a baby born at the University of Alabama. He is the world's most premature survivor, according to Guinness World Records. He was born at 21 weeks and 1 day and is reported to be doing well. This is a baby named Elijah, born at the University of Iowa at 21 weeks and 3 days. This photograph was taken at his postmenstrual age of 40 weeks. He was still in the hospital. He was discharged at 43 weeks postmenstrual age on nasal oxygen, full oral feedings, and no oral medications except vitamins. His oxygen was stopped at 9 months, and he was showing good catch-up growth. And here he is at 11 months when he was discharged from follow-up clinic with one of his doctors, Dr. T.J. Boley. There have been several case reports of 21-week survivors, including this one from San Antonio, Texas, who was reportedly doing well at 2 years. The Swedish National Quality Register has been reporting 21-week survivors for some years, and there were 9 survivors during this period from 2014 to 2019. We look at viability in terms of gestational age because it's convenient and it's a simple, easy measurement. But we have to keep in mind that gestational age is not the same as maturity. The 21-week babies I showed you were babies who were unusually mature for 21 weeks. They were out at one end of this bell-shaped curve. And we know quite well that other factors besides simply gestational age factor into a baby's chance of survival. This paper published by Matt Rashavi in 2020 was an update of the Neonatal Research Network model for estimating survival chance, originally published in 2008 by John Tyson. It's accompanied by an online tool that allows you to enter the baby's true or estimated birth weight, the gestational age, the sex, whether the baby is a singleton or a multiple, and whether the mother received antenatal steroids. And you can then calculate the baby's chance of survival, either as a percent of all babies, including those not actively treated, or the more useful number of percentage of babies actively treated. You can also get some prediction of the baby's chance of handicap. This tool is available on the NICHD website, and it shows you that there are these other factors besides gestational age are quite important in determining a baby's chance of survival. If your hospital is a member of the Vermont Oxford Network, you can get hospital-specific predictions of the baby's chance of survival, which are quite useful. Here, for example, you can see the survival chance for 4 different hospitals for a female infant born at 22 weeks who weighed 500 grams, was a singleton, and whose mother received steroids. And you can see that from hospital 1 to hospital 4, the survival chance ranged from 59% to 31%. Here are 2 example babies using the NICHD tool that show that a 23-week female with a good birth weight, was a singleton, whose mother received steroids, can have a better survival chance than a 25-week male who's smaller, was a twin, and whose mother did not receive steroids. So this is a good example that gestational age doesn't tell the whole story. So once again, at 22 weeks, more than half of actively treated infants survive in selected centers and in several national cohorts. At 2 to 3 years, 1/3 to 1/2 of 22-week survivors have no or only minor neurodevelopmental impairment in several cohorts. But gestational age is not the same as maturity. The new extremely preterm birth outcomes tool may help to predict the survival chance for a given infant. And although I didn't show the data to support this, standardized approaches agreed on by providers improve outcomes and patient experience. Now, what about birth weight limit of viability? How small is too small? This baby girl born in Singapore weighed only 212 grams and survived discharge. And the last I heard, she was doing well at home, although she was still requiring some respiratory support. She's the smallest survivor that I'm aware of. This is the homepage for the Tiniest Babies Registry. The easiest way to find the registry, if you're interested, is just to Google Tiniest Babies Registry. This is a web-based registry of children who survived with birth weights below 400 grams. The registry was started in January 2000 with 15 patients. As of October 6th, there were 304 patients. The birth weights range from 212 grams to 399. There are 45 infants with birth weights below 300 grams. The gestational ages range from 21 to 34 weeks. And not surprisingly, all except 12 infants in the registry were small for gestational age, with birth weights below the 5th percentile by the Alexander birth weight curves. And 69% of the infants were females. Here you can see the gestational age distribution. The 34-week infant was born in the 1930s, and so I don't know for sure how accurate the gestational age or the birth weight is. Here are the years of birth. Oddly, there were 3 infants I found reported in the 1930s with birth weights below 400 grams. And then there were none for 50 years. And we started to get some in the 1980s. Here are the countries of birth. The top 3 are the US, Germany, and Japan. There are very few from Asia. This was the girl who, inspired by interest in tiny babies. I was on duty when she was born in 1994, and her parents asked me, "Do you know other babies this small who have survived?" And I told them I had heard of one that I had read about in a magazine, and that was born in 1989 in Chicago, and offered to try to see if I could find others. This is the one that I had read about in People magazine. She was later reported in the New England Journal of Medicine, and she was the smallest baby in the registry for 15 years. She's now the 25th smallest, and she is a university graduate, and I think she's a school teacher. This is a little boy from Iowa. This one is also from Iowa. And here she is at 4 years. This is another from Iowa and another one from Iowa. How do these tiny babies do long-term? We have limited long-term outcome data for the children in the Tiniest Babies Registry because we don't attempt to systematically collect long-term outcome data. We have only data that the patients or parents elect to send us in follow-up. But what we know is that most patients weigh less than average for age, and many are shorter than average. Some experience delayed development and more serious health concerns, but we do have some more systematic data from the NICHD Neonatal Research Network, Extremely Preterm Infant Registry. And we published this paper in 2019, looking at babies from the registry who survived with birth weight less than 400 grams. We had 19 infants who were evaluated at 2 years. 12 of them had weight, length, and or head circumference Z-score of -2 or worse for age. 12 had required rehospitalization at least once in the first 2 years. 9 had feeding problems. 7 had pulmonary problems, and 8 required some form of medical equipment use at home. At 2 years, of the 19 infants evaluated, 5 had impaired vision, One had hearing impairment. None had autism spectrum disorder. 11 had abnormal neurological exam, including 3 with cerebral palsy, and their median Bailey scores were in the 70s. These were the definitions used for neurodevelopmental impairment. Among these 19 infants, only 5 had no or mild neurodevelopmental impairment, 5 had moderate impairment, and 9 had severe neurodevelopmental impairment, including 1 with profound impairment. But keep in mind that these infants had growth failure in utero, most of them quite severe, and this increases their risk of adverse neurological outcomes. And in most, the poor growth continued throughout infancy, which is a critical period for brain growth and development. So I think it's not surprising that these severely growth restricted infants had worse neurologic prognosis than even the 22-week infants who were most of them appropriately grown in utero. So to summarize it, if we look at gestational age as a limit of viability, nowadays in the US and many European countries, the limit is 22 weeks. And more than half of actively treated infants survive in selected centers and in several national cohorts. Based on limited follow-up data, 1/3 to 1/2 of 22-week survivors have no or only minor neurodevelopmental impairment. But we need more data on follow-up at 2 or 3 years, and particularly later on at school age. In terms of the limit based on birth weight, from the NICHD study I told you about, 26 of 101 actively treated infants with birth weight under 400 grams survived to discharge, but of the 19 examined at 2 years, the results were not encouraging, and almost half had severe neurodevelopmental impairment. So we have somewhat encouraging data, but for at least the most premature babies, for the severely growth restricted babies, the data are not as encouraging. So it depends on whether you view this cup of water as half empty or half full, or as my colleague John Daigle says, the cup is entirely full, but it's half water and half air. Thank you for your attention. I look forward to answering some questions.
Thank you so much, Professor Bell. It was an amazing lecture, just like going through a wonderland. So we would straight away go on to the panel discussion. I would invite Dr. Jyotsna Srivastav and Dr. Pradeep Devada to kindly take over.
Okay,
yes,
ma'am, continue.
It was really amazing to see such tiny dots, and you have a very good follow-up for such a long period. And it is really amazing to see that the disability keeps on decreasing with the going age, probably because of the good rehabilitation services. What I feel is that. So there are certain questions I will hand over to Dr. Pradeep. You just go ahead for the questions. But yes, I am really concerned about that in India. Should we make it mandatory to give steroids as a routine? Because we'll end up most of the time in the state when the patient is already in labor. So antenatal steroid, though it is recommended, but what the population coming to us is most of the time it is already in premature labor and they are not able to complete the course of antenatal steroids. Over to you, Dr. Pradeep, you go ahead.
Thanks, ma'am. So the scenario in a developed country and developing countries like India is totally different. Before going to the questions that is there in the chart, I have a question for Professor Bell. What I think I have read in articles from UK, one is from UK, that these the percentage of this tiny baby or periviable neonate, the percentage is very less. It is even less than 2% in developed countries. And what they have written that the total consumption of budget of neonatal unit, it takes about 20 to 25%. So have you ever estimated in your NICU how much expenditure for such tiny babies of the total budget for the NICU?
Haven't estimated in dollars, but in terms of beds occupied, these babies, if they survive, they stay a long time. And so they do occupy more than their share of the beds in the unit. And so this is an important consideration. And perhaps not every hospital or every country should be attempting to save 22-week babies. I think that's a very fundamental policy question. My purpose was just to report what's happening, in the most advanced hospitals in the most advanced countries. So, before you try to save 22-week babies, you have to have good results at 24 weeks. And before you do that, you have to have good results at 26 weeks.
Thanks, Professor Bell. Rightly said, it is before going for a policy, we need to see our own statistics, what we are doing currently. Obviously, and secondly, in developing countries, it is very difficult to support those families who have such neurodevelopmentally challenged children. So that is another challenge for the developing countries to support them. The state, particularly the state, doesn't support them. So it is their individual effort to rear that handicapped child. So it becomes very difficult for the family itself also. So now coming to the questions, those are posted in the question and answer box. One is by Dr. Maria M. Murillo, but that's I don't know what is the language.
Yes.
It is written in some mostly French, I think. I
It
don't
is
know.
Spanish, no?
Yeah.
So,
Professor Bell, can you read Spanish? Otherwise,
No, but I could try to use Google Translate, perhaps.
and coming to the next question, Dr. Anand Pondekar, the resuscitation guidelines in India, at what lowest gestation age can be resuscitated? We can get this comment from ma'am or Dr. Manoj.
I think the latest recommendation is even in India, we are targeting at 20 to 24 weeks. And previously it was 24 to 26 weeks. For all practical purposes, with my long experience, I still recommend let us target up to 24 to 26 weeks. Like it's a really futile exercise to save such children. Government cannot afford, we cannot really have, I'm not talking about the few percent of population who is being treated in the private hospital. And later on, after 15, 20 days or a month, then they get shifted to the government hospital with all drained money and complications. So I think let us stick to 24 to 26 weeks, though the recommendation has gone down to 22 weeks. As it is advanced NRP, we are following the American Academy guideline. Comment from Dr. Manoj, please.
Dr. Manoj, any comment from you?
I beg to differ a bit, madam. Actually, India, just to speak of India, India is a country of so much of diversity. We have state-of-the-art facility coexisting on one end, and on the other end, we have even lack of primary care facilities. So when you, it depends on your unit policy, whatever, or rather your unit data. So there are units which have reasonably good survival rates for 23 weeks and 24 weeks. So such centers, and I think the message had been given by Prof Bell in the sense that you need to save 25 weeks before you go on to 24 weeks. Then once you
Yes.
get that right, so we need to, this is evolution. So we continue to learn until you look up, you will never go up. So probably we need to go in that line, but at the same time, the financial considerations, I agree, is a big challenge most of the
You
time.
know, what I feel, Dr. Manoj, that majority of the government setup, they are overburdened. So it is basically, that is what I say, leaving aside a few neonatal units in institution like AIMS, where they have limited bed and they can refuse no more admissions. So they can continue with such inborn children and they can continue to treat them. And what about the like private setup? It is so expensive. So the majority of, there was a World Bank report that the majority of our population goes into a lifelong debt
Point
because
taken,
they
ma'am.
are
Point
treated. Yeah.
taken. Let's move on
Yes.
to
So,
the
Yes. Next
no,
question. Next
just as,
question.
let me conclude this. Current guideline is to give steroid between 24 to 34 weeks. So
Yes.
resuscitate the babies who are more than 400 grams or more than 24 weeks. That is the current recommendation from our government of India. You have to resuscitate and give antenatal steroid those who are between 24 to 34 weeks. Okay.
Yes.
Going to the next question, Dr. Bharat. He's saying that I'm sure for every 22-week mother who delivers, you would be giving several mothers steroids who thankfully do not deliver in the next week or so. Do you advocate a second course of steroids to such mothers to get the best neonatal outcome? Professor Bell, second dose of antenatal corticosteroids
Yes.
who are not delivering within 7 days.
Our obstetricians will give a rescue dose after several weeks, but not we don't repeat the course every week like they did some years ago, because that's been shown to have some adverse consequences. I don't know exactly how many weeks they will wait. It's at least 2 weeks before they'll give another single dose of betamethasone.
SEOG recommendation is to repeat the dose if the baby does not deliver within 2 weeks of giving that steroid. So we can follow that, and in India also you can give a rescue dose after 2 weeks if the baby is not gets delivered. So going to the next question, again Dr. Bharat has asked, Japan NICU are small units with very small number of doctors and NICU nurses and allied staff. Does this mean smaller focused NICUs could be the way forward to minimize the variation in the practice to improve the outcome? Professor
Yes.
Bell.
Yes, I think we have a large unit, but it's divided into 4 different areas, and we do have one area where we tend to keep these tiny babies, and we have a group of nurses who specialize in caring for the tiny babies. We don't have a designated tiny baby unit that's where we care for only tiny babies, as some hospitals in the US do. We also have very sick big babies in this area, but I think it does help to concentrate the expertise with the providers who are interested and enjoy caring for these babies, and the more experience they have with caring for them, the better results we're going to have. So I think that in a way that mirrors the Japanese approach.
So the summary is for at least for the tiny babies, we should have separate areas and and expertise for management of such tiny babies, and that would give us a good result.
Yeah, and I think that should apply for you, for your tiniest babies, whether they're 25 weeks or 24 weeks or 23 weeks. Yeah.
Thank
So,
you, Professor Bell.
yes.
Okay, Dr.
Next
Josna.
question, yeah. The next question is Sumesh Parat. He is asking, like, can you please share the data about long-term problem with 22 compared to 23 and 25 weeks? You mentioned earlier that it was same. I think he had already explained in the next few slides. So, Dr. Bell, please answer this question.
Yeah, based on the relatively small number of 22-week babies for whom we have 2 and 3 year outcomes, there doesn't seem to be any, the risks, adverse outcomes don't appear to be any more frequent than they are for 23 and 24-week babies. You skipped another nice question by Dr. Bharat.
Yeah. That Japan NICU seems to practice a lot more functional echocardiography and almost daily use of suppositories to help bowel emptying. They use usually glycerin enemas and suppositories. And please share your experience in above. And they, in fact, have reported low incidence of NEC as well because of giving such suppositories, glycerin suppositories.
Yes, we also practice a lot of functional echo. We have a neonatal hemodynamics team that is very active in our unit. In fact, we have a neonatal hemodynamics fellowship program, one of very few in North America. And I believe this also helps to contribute to our good outcomes. And we also have identified a problem that's been reported by the Japanese and others that has various names. It's a meconium obstruction syndrome that we see in these babies that does respond to various approaches, including the use of suppositories. It causes an obstruction that can lead to bowel perforation if it's not managed carefully.
My question, Dr. Bell, to you. Regular use of suppositories, does it really decreases chances of NEC?
Yes, we have a very low incidence of necrotizing enterocolitis. I attribute that also to our universal use of breast milk. Almost all of our babies get mother's own milk, and if they don't have enough, they get donor milk from our milk bank.
Okay. And any, do you frequently use probiotics to prevent NEC?
Yes, we use probiotics.
Okay, thank you.
Even the Japanese units also, they use probiotics in their NICUs. Okay, then moving on to the next question from Dr. Raj Kishore. How many babies require surgical interventions in such tiny babies, among such tiny babies?
I can't tell you the number, but it's low because we have a low incidence of neck, and if babies require PDA closure that doesn't respond to medication, we close them through a catheter with a plug. So we don't have a lot of surgery.
Okay. So ma'am, continue.
Next, Shivji Ramchandra Hegde. So what oxygen saturation level is okay since we have to keep baby on ventilator? HFOV or any other mode you prefer, Dr. Bell?
Initially, we will target the oxygen saturation of 85 to 95, and we routinely use high frequency jet ventilation for these tiny babies. We believe that's the the least damaging to their very fragile terminal airways.
Routinely you intubate such tiny babies and keep invasive ventilation for respiratory management.
Yes, and we use 2.0 millimeter endotracheal tubes for most of these tiny babies. Anybody under about 450 grams, certainly.
Okay, thank you, Professor Bell. Then that next question by Dr. Sumesh. Do you offer antenatal corticosteroids in your unit at 21 weeker or just after 22 weeks?
Our obstetricians will begin to give antenatal steroids at 21 weeks and 5 days if resuscitation is planned at 22 weeks, so that the fetus can have the benefit of full 48 hours of steroid exposure.
Thank you, Dr. Bell. The next question is Iman Badrin. Any role of magnesium sulfate in these babies? Is there any role of Dr. Bell?
I'll answer this in two parts. The first is magnesium sulfate to the mother for neuroprotection of the fetus, and our obstetricians will do this occasionally, and I can't tell you exactly what their indications are. We include magnesium sulfate in our parenteral nutrition solutions for the babies, but we rarely need to give additional supplementation.
Not routinely to the mother for neurodevelopmental better outcome?
Routinely.
Not routinely.
Not routinely.
Okay. So next question is by Umida Geneva. He writes, thank you for the very informative lecture. Is there any data regarding the difference in survival between male and female babies? It always seems to me that the female babies survive in more cases, but maybe it is just my subjective assumption. So what is your experience, sir?
Yeah, there's a well-known female advantage, survival advantage in extremely preterm infants. And as I showed you there, 69% of the babies in the Tiniest Babies Registry are females. We are in the process of looking at recent data from the NIH Neonatal Research Network and to see whether this discrepancy has continued or has narrowed over recent years. I think your impression is right.
And for that, I think the outcome score itself has a column for sex of the baby, either male or female child.
Yeah, that's exactly why.
Thanks.
The next question is Dr. Madhu Chandran M. What are the additional spatial interventions that were followed in these extreme preemies, 22 to 23 weeks, other than regular 25 to 28 weeker preterm? Dr. Bell, please. Any spatial interventions?
Well, you know, I mentioned that at Iowa, we preferentially ventilate these babies with high frequency jet ventilation, but in Uppsala, they do not. In Nagano, they do not. And in Cologne, they don't even intubate the babies. They give them Lisa. They give them surfactant by Lisa and put them on CPAP. So, and we all have excellent outcomes. So I don't know that, you know, and we keep our babies on radiant warmers. The other places keep them in incubators. People use different levels of humidity. The one thing we all have in common is the belief that these babies can survive and have good outcomes. So I don't know that, that the specifics of care should be the overriding consideration. I think is what you do well and have good results with. We can tell you how we do things at Iowa, and we have published some papers about this. If anyone wants to email me, I can send you some papers that contain details of how we and some of these other centers do things. But I think the most important thing is the culture.
Okay, so there is variables in the lines of treatment and different modes of treatment. So still we are hoping for a good outcome. So next question, coming to the next question, it is Dr. Nargis. How early do you shift the 22-weeker babies from invasive mode to non-invasive ventilation mode?
We let the baby tell us when we get down to certain settings on the jet ventilator. Then we switch the baby to nasopharyngeal NAVA. So it's typically going to be a few weeks, but we don't rush to extubate the babies because we know that babies who fail the first extubation don't do as well long term.
Okay, sir.
The next question, should I ask Dr. Pradeep?
Yeah, Dr. Josna, go ahead.
The next question is Derisha Pillai. She works in a private NICU in South Africa. So she is writing, we currently have a 25-weeker, which was born with a weight of 580 grams. Baby is currently oscillated, essentially on CPAP setting and maintaining her PO2, CO2 and saturations. Is there benefit to keep baby oscillating to facilitate lung growth? And if so, until which gestation age or weight do you suggest? Dr. Bell, please answer.
That might be determined by how you plan to deliver CPAP when you extubate the baby. If you're going to use nasal prongs, how big does the baby have to be for the smallest prongs that you have? Or if you're going to use nasopharyngeal CPAP, the baby will have to be big enough for the tube to fit the nose. So I guess, that might be one consideration. But I would say probably in general, you're going to want the baby to be at least 800 grams.
Okay.
Okay. Next, moving on to the next question, again by Dr. Nargis. Do you practice vitamin A, surfactant plus budesonide, fluid resuscitation strategies? How high do you go on fluid intake, daily fluid intake, total fluid intake per day?
We do give
Vitamin A and
baby.
surfactant only or surfactant plus budesonide, and about fluid resuscitation or daily fluid requirement.
We give vitamin A for babies under 1,000 grams. We do not give surfactant and budesonide, but we are participating in a randomized clinical trial to study this. We do not, our fluid strategy is to, because we use radiant warmers, we have to give babies a bit more fluid than you would if you were keeping the baby in an incubator, because we have higher insensible losses. And that enables us to give the baby more intravenous nutrition, which we start quite early on. We start really on the day of birth, and we start lipid by the following day. So we give just enough fluid to meet the baby's needs and don't overload the baby, so that.
So every day monitoring the weight and by echocardiography, we need to decide the fluid intake. total
Yeah,
body.
we
Yes.
monitor the weight and the sodium.
Sodium. Yeah.
Yeah.
Thanks.
One more question from Nargis. What policy do you follow in your unit, Dr. Bell, for screening for IVH and PDA?
For IVH, we routinely do the first ultrasound at 7 days unless we have concerns that lead us to do it sooner. As I mentioned, we have a very active neonatal hemodynamic service, and so we will often we will routinely do a screening for PDA at 48 to 72 hours, and so we watch pretty closely for PDA. If we see a significant PDA early on, we treat with acetaminophen.
Okay, the next question by Dr. Anjali Raj. How many times can we repeat the rescue dose if the delivery is still not imminent? That rescue dose of antenatal corticosteroids is asking about.
Once or twice.
Once or twice.
Yeah.
Thanks, sir. Now, next question, Abhijit Singla. Sir, he is congratulating you for the excellent talk. And his question is, how much do you think, in your opinion, jet ventilation play a role in survival of these periviable, extremely preterm neonates?
I don't know, but I think it plays a role. I can't tell you how much. I wouldn't want to ventilate these babies with conventional ventilation, because when you try to fully inflate the lungs with each breath, you're creating shear forces that I think set you up for lung injury and increase the risk of more severe bronchopulmonary dysplasia. Having said that, there are centers in the U.S. and Sweden and Japan that have excellent outcomes that use variations of conventional ventilation. So we are believers in high frequency jet ventilation. We used a high frequency flow interrupter before the infant star was retired from service. But I wouldn't say you all have to go out and buy jet ventilators if you want to have good results.
Okay, sir, before going to next question, I have a question in my mind. What is your experience, whether the small for gestational age babies, they survive more than the appropriate gestational age babies in these 22 to 25 weeks? What is your experience? Because in one of your slides, you just discussed that the neurodevelopmental outcome was whatever it was there, because the babies were mostly small for gestational age. So the outcome may be better if for appropriate gestational age. But what about the survival? What is your experience? It is better in small for gestational age or inappropriate for gestational age?
It depends on the gestational age and the size. I think small for gestational age babies mature their lungs faster, so they may have an advantage, but it depends whether you're comparing them to babies of the same weight or the same gestational age.
I hate to interrupt. Professor Bell, how much time do we have?
As much as you want.
Oh, all right. Because I know that you got the commitments after this also. Then fine. Okay. Fine.
I have another 45 minutes if you want.
Oh, great.
Okay. So next two questions from Dr. Nargis. Do you feel that family-centered care is improving neurodevelopmental outcome? 1. 2. How early you start KMC in your unit, sir? Number 3. What brand and what strain of probiotics you use? Dr. Bell, please. Hello.
Yes. Family-centered care is very important. We've been engaged in that since the 1990s. We have families always welcome in the unit, including during physician rounds. We have single patient rooms, so the families can stay in the room with the babies if they want to. I don't know if it's improving neurodevelopmental outcome, but my guess is the more the parents are there, the better it is for the babies. I think having the parents present is like having another provider for the baby, because the parents know the babies better than anyone, and they sometimes notice things that we haven't noticed. So we encourage them to let us know if they see a change in the baby or think something's wrong. So I think that's critically important. When we allow the parents to hold the babies, depends somewhat on the gestational age, and the nurses have a guideline for this. We don't want them to pick up the most extremely preterm babies for first week or two because of concerns about perturbing cerebral blood flow. So the 22-week baby, for example, can't be held for the first couple of weeks. But if it's a 28 or 30-week baby, it may be possible in the first few days. But we do encourage kangaroo mother care. We use a probiotic that is called Florida Baby. I think it's changed its name, but it's the same one that Keith Barrington from Montreal has reported using. It's just looking it up to verify. Ultimate Flora Baby. We've been using it for a few years. Our incidence of necrotizing enterocolitis was quite low even before we started using it. So it's not been possible for us to detect a further reduction.
Okay, so sir, there is no barrier. What is the weight cutoff to start like kangaroo mother care? Is there any cutoff of weight or gestation that when you start giving mother to go for KMC care?
No, except as I said, for the most extremely preterm babies, we don't let the mothers pick them up because of concerns about perturbing cerebral blood flow. So we don't want the baby to be held vertically or just because we're afraid the brain might underperfuse. So we'll wait a couple of weeks for those babies.
Okay. So next question by Dr. Abhijit Singla, and he wants 5 take-home message points from your experience to have a better outcome in such tiny babies. 5 points from your experience. So what would be those 5 advice for the better outcome of such tiny babies from your experience?
Well, I think, sorry, I don't know if I can come up with 5, but I think the first thing is we don't know what the future holds. Because as I said 20 years ago, I said that we're never going to go earlier than 24 weeks. And and now here we are at 22 weeks. So people ask me what's next, and I say I don't know, because are we going to have the possibility for 21 or 20-week babies? I think so. Be humble and wait and see where the future takes us. Learn from your patients. Engage the families and let them have as big a role as possible. I think my ideal unit would, if we had unlimited space and money, I would build a unit that was big enough for the family to have a room adjacent to the baby's room, so that families could participate more in the care of the babies. Work closely with your obstetricians, because without them, none of this is going to happen. And pass it on to the next generation. I don't know if that's 4 or 5, but those are, maybe you're looking for detailed medical prescriptions, but I think those are the lessons that I've come up with from my career. And that's not just for the 22 to 24 weekers. That's for all the babies.
So we need to have patient for to make them survive, and we should learn from our own experience how to get better and better.
The
Thank you,
next
sir.
question, yes. The
Carry
next
on, ma'am.
question,
Carry on, ma'am.
the next question from Dr. Anjali Raj: which probiotic is preferred? Probably Dr. Bell has already answered it.
Yeah, and it depends what's available in India. I don't know which ones are available to you.
So the next question is, do you have any routine policy to manage PDA?
Yeah, as I mentioned, we screen them starting pretty early, and if it's hemodynamically significant, we treat them with acetaminophen. We may treat several courses. If that doesn't work, we may try indomethacin or ibuprofen, and eventually, if we need to, we will have our cardiologist close them with an Amplatzer plug device. If that's not feasible, we rarely will have the surgeons do it, but we have a very engaged neonatal hemodynamics team. The head of our division of neonatology, Dr. Patrick McNamara, has spoken in this series before, and he's not only a neonatologist but a cardiologist. So we have very good support.
Yeah. So the next question comes from Sivji Ramchandra, and his question is, when do you start feeding in a 21-weeker baby? Enteral feeding.
As soon as we have colostrum.
Okay. And the next question from Anand is use of an antenatal magnesium sulfate 24 to 26 baby. We have already discussed that. And next question, how from Anwar Khan, how is the fluid management? He means to say, again, we have already discussed this. Ma'am, next question, can you?
Thomas John is asking, are there statistics to show the trends in outcome, morbidity and mortality of babies born very preterm as more extreme preterm are looked after? In other words, without optimal neonatal nursing quality, number isn't the nursing care of more mature babies diluted. For example, sepsis rate in more mature preterms may increase as the challenges of looking after 22 to 23 weeker in increasingly prioritized. Hence, in less affluent countries, national policies should be formulated taking into account resources for acute care as well as subsequent follow-up and family support. Your comment, please, sir.
Well, we're fortunate in the US that we have the resources to care for these babies' needs, both in the hospital and afterwards. And whenever the cost of NICU care comes up, I remind people that we, in the US at least, we spend much more on cigarettes than we do on newborn care, and we spend much more on dog food than we do on newborn care. So it's a matter of setting your priorities.
So the next question is from Dr. Bharat again, and he's asking like your experience of using postnatal steroids as recommended by Premilog study to help reduce BPD in such tiny babies. Postnatal steroid.
We are not routinely using steroids to reduce the risk of BPD, although we've participated in several randomized clinical trials, including the NICHD Neonatal Research Network trial that was published recently by Dr. Waterberg in the New England Journal of Medicine. There was no impact on the primary outcome of neurodevelopmental impairment or death, although the babies were extubated a bit earlier if they were given hydrocortisone. We do use hydrocortisone in many of these extremely preterm babies for blood pressure support. We find that some of them appear to have adrenal insufficiency at birth, and so they need hydrocortisone for a period of time.
Oh, okay. Next question is from Dr. Anjali, that she's again asking about what is your take on high frequency oscillatory ventilation versus SIMB plus volume guarantee as primary mode of ventilation. HFO versus SIMB plus VG.
Yeah, I don't know how to answer that because we don't have much experience with either of those modes.
SIMB,
Since we use the jet ventilator.
Jet ventilation, yeah.
Yes. Oscillatory ventilation is not much. Anwar Khan is asking, how is the fluid managed? NT policy in such tiny babies restrict or liberal?
We don't give restricted or liberal. We give just what they need.
Yeah, it's part the requirement. We have already discussed about
it's not, yes.
that thing. Yeah. So
Nargis,
yeah.
Nargis is asking how early you start feeding in these 22 weeks, and do you follow slow increment or fast increment at up to 30 ml per kg per day?
We start early, so we will give colostrum as soon as we get it, typically on the day of birth or the following day, and we increase slowly, typically 10 to 15 ml per kilogram per day.
Okay. So the next question from Sivji Ramachandra. What level of blood pressure you accept in this initial 48 hours when there is a higher chance of IVS in this period of time? And do you use inotropes? If so, which one?
Well, that's a good question. Nobody has a very clear idea of what's the normal blood pressure for these babies. And I must admit, we still tend to hang our hat on the old idea that the mean blood pressure should be at least the same as the gestational age in weeks, but maybe it should be a bit higher than that. We do rely on our neonatal hemodynamics people to assess the LV function and the perfusion, and we do sometimes use inotropes on their recommendation, and we've used several different ones: dopamine, dobutamine, even vasopressin occasionally, but I prefer to avoid those if we can. We would typically start first with hydrocortisone to make sure that we're not dealing with adrenal insufficiency.
So next question is from Nargis. What else do you add in TPN apart from carbohydrate, protein, lipid, calcium gluconate, phosphates, and magnesium?
Vitamins.
Right. Yeah.
Right, right. The next
So-
question, yeah.
Yeah, ma'am, continue.
Dr. Pradeep, go ahead.
Okay. The next question is from Dr. Susma, and her question is, can routine antenatal corticosteroid to all mothers after 21 weeks of gestation be recommended? At times, the premature delivery is unexpected. We have already discussed a lot about this question. So we can move on to next question. So he thanks you, Professor Bell. And his question is, what are the developmental issues in terms of behavioral disorders like ADHD and autism? And is there any gender difference in your follow-up for such tiny babies? Behavioral disorders, autism and ADHD.
Well, we don't have enough 22-week babies to address these questions specifically for this group, but in general for extremely preterm infants, there does appear to be an increased risk of behavioral disorders and autism. Although, you know, these conditions are fairly common in full-term children too, so it's always hard to know for sure how much of this is attributable to prematurity. We don't. I can't answer your question about gender difference. I don't know if we've looked at that in our data.
Yeah, of course, because we need to have more data on this.
Yeah, autism is otherwise, it has a high incidence in the male population. But what about these survivors that we really don't know? Dr. Abhijit Singla has asked, do you also use prophylactic hydrocortisone for BPD in these peri-viable newborn and day 1 of life?
No.
Okay.
Yeah, already answered this question,
Yes.
Professor Ben.
So on day 1 was very peculiar, right? Ramchandran Hegde, currently we have chart for treating hyperbilirubinemia down to 23 weeker. Have you got it for 20 weeks also? For nomograms for hyperbilirubinemia.
I can't answer that.
Yes, please, sir.
I don't know.
Okay, but the data is not available. Up to 23 weeker, yeah, we have that data from NICE guideline.
And
So,
that,
so we can move on to next question. So Adesanya, Dr. Adesanya, then he's again congratulating Professor Bell for a great presentation. The question is, do you have the data comparing the race and social determinants of health in limits for these survivors of gestational age between 21 to 26 weeks?
We are looking at these factors, particularly social determinants of health right now in this population. We do have some, we've published a paper on effects of race and ethnicity on outcomes. And there has been traditionally some differences, some impact of race and ethnicity on survival in extremely preterm infants in the US, with Latino babies having a slightly higher survival and African American babies having slightly lower survival. But the most recent analysis shows that these differences are becoming smaller. That was published a couple of years ago in JAMA Open Network. But we're just now doing analyses of the social determinants of health and their impact on outcome. Thank you for that question.
And some articles also have shown that ROP is more common in Asian origins in such tiny babies.
Yes.
Retinopathy of prematurity. Those are more common in Asian origins babies.
Yes.
So
next question is, Dr. Anjali, what is the rate of extrauterine growth retardation in these babies? Isn't feed intolerance a problem with them?
We have outstanding nutrition support in our NICU, and if these babies are appropriately grown in utero, they tend to follow a good growth pattern after birth, and it's not a particularly big problem for us.
Yes, that was very well visible in the pictures at the age of 5 months or a year or so. Right. The next question, do you use prophylactic indocin for the extremely premature less than 26 week gestation to prevent severe IVH?
No.
okay, so no prophylaxis. Okay. So next question, Dr. Narkis. What is the rate of EUGR for less than EUGR? Extrauterine growth retardation for already answered.
Already.
Okay.
Yes.
For the vitamin A given to babies less than 1,000 grams, is it given as intramuscular?
Yes.
Yes.
We give the same regimen that was reported in the Tyson New England Journal paper in 1998.
Okay.
It may be that vitamin A could be used orally, but I don't think the correct dose has yet been established.
Yeah. So, Dr. Nargis, the next question is, do you routinely sedate the babies on high frequency jet ventilation during invasive ventilation?
No,
we
do
sedate
not.
The baby? Yeah. And yeah, ma'am, continue.
Dr. Anjali, what do you think these kids are ready for KMC? Is feeding protocol any different from those for these tiny preemies? I think
No,
it has already been discussed.
Yeah.
It's
Yes.
not any different. We feed them the same.
Yes. The next question is, for management of extreme premature infant, do you use postnatal steroid, this I think for BPD prevention or to help extubation? If so, when and which steroid, dexamethasone or hydrocortisone? Thank you. So it is prophylactic has already been discussed postnatally. For extubation, are you using it routinely, dexamethasone or hydrocortisone?
We don't use steroids routinely for extubation, but occasionally, if we have a baby who's failed extubation previously, we may use dexamethasone or hydrocortisone, and excuse me, we sometimes will use dexamethasone or hydrocortisone for a baby with lung disease that we're having some difficulty weaning from the ventilator.
Okay, so the next question again from Dr. Abhijit. What is your experience on non-invasive nasal high-frequency ventilation? Do you, in your unit, ever use this mode of ventilation, and how do you select those neonates?
We've published a paper on this mode, but we don't use it clinically.
So next again from Anjali Raj, she's saying that we have seen small for gestational age in our setup, though do not have issues with ventilation. We face a lot of feed intolerance and also land up in NEC due to in utero mesenteric insufficiency. So is feeding protocol any difference in them for small for gestational age babies? Is there any difference in the feeding protocol?
No, I guess we would just watch them a bit more carefully and advance their feedings more cautiously. We do check gastric residuals, and we don't advance the feedings if the residuals are large.
Okay, same precautions that we took in extreme preterm. Those are the things to be taken care of. Okay, so next question by Madhu Chandran. What is the incidence of pulmonary hemorrhage in these 22 to 23 weekers compared to our 28 weekers? Do you routinely use surfactant as treatment for pulmonary hemorrhage?
Pulmonary hemorrhage is very rare. I can't remember the last time I've seen it, but yes, once the hemorrhage is controlled, I think we probably would give surfactant because we would assume that the endogenous surfactant would have been inactivated by the blood.
Right. Dr. Abhijit Singla wants to know, could fellows from India get neonatal hemodynamics training at Iowa?
This may be possible. You should contact Dr. Danielle Rios.
Okay, so it is possible.
There's a lot of demand for this training. We have many international people who come for training, and so the program is very busy. So you may not be able to do it for a while until there are openings available.
So you have to be in queue for that.
Yeah.
So next is from Dr. Nargis. For how long do you administer antibiotics if blood culture culture negative, but has central line in situ and endotracheal tube in situ? How frequently you screen for metabolic bone disease? Though recommendation is once in 2 weeks, I ask because of what she writes, because of fear of anemia requiring blood transfusion. What is the blood transfusion incidence in your unit? Do you routinely use erythropoietin? So 2-3 questions at a time.
Okay, so antibiotics with the negative blood culture, if the baby is well, we will stop the antibiotics after 36 hours. If the baby is ill, we'll continue the antibiotics. And the presence of a central line or an endotracheal tube doesn't make any difference. We screen for metabolic bone disease. I don't know if we have a routine for this, but if the baby is on TPN, we'll be doing some screening. But if we see osteopenia on X-ray, then we'll screen. We don't screen every 2 weeks or anything like this. We transfuse according to our transfusion guidelines.
Good.
We do not use erythropoietin except in unusual situations, such as a baby in renal failure or parents with religious objections to transfusion.
Okay, thank you, Professor Bell.
My question to Dr. Bell is, like, can there be, in case of blood culture negative and central line and endotracheal tube in situ, can the platelet count or the consistently platelet count going down can be a good guideline to start antibiotic suspecting sepsis?
We would look for the source of the thrombocytopenia, and sepsis would be one possible consideration. But we would We would look also at the white blood cell count and the differential and the C-reactive protein.
Okay. Right.
Okay. So the question from Nargis, do you routinely fortify or only when weight gain is not appropriate? How early you are fortifying the milk, and what do you use for fortification? Fortification of milk.
We routinely fortify the human milk that we feed to preterm babies. And we start this when the baby gets to take about 75 ml per kilogram per day. And we use a bovine-based
Fortify.
human milk fortifier, a commercial fortifier.
Okay. Dr. Sugna Reddy, she wants to know for in relation to IVH, is there any advantage of LSCF? What is the preferred mode of delivery for these babies?
I think the latest data I've seen do not indicate a clear advantage to the baby from cesarean delivery, unless it's a breech. The ideal way to deliver a 22-week baby would be to deliver it on call. Very few obstetricians recognize that and do that, but I'm always happy when I see the baby is delivered on call, because then you have this natural protective cushion of amniotic fluid around the baby.
Yeah. So coming to the next question, it is by Dr. Kiran. And so do you start only trophic feeding at the beginning, and for how long you continue with your trophic feed? Then you escalate.
No, we don't call them trophic feedings, but we start with small volumes and increase slowly. So we don't wait to increase the volume. We'll start with, for a very tiny baby, maybe 1 ml every 8 hours, and then the next day we'll go to 1 every 6, and then 1 every 4, and then 1 every 3, and we tend to stick with every 3-hour feedings. but we increase every day if the baby's doing well.
Dr. Nargis is asking how early you screen for thyroid function test, as 1 ml of blood will be needed if cord blood TSH was not performed. Do you add sodium and potassium since day of birth or after 48 hours in TPN?
I don't remember when we first do the thyroid function screening, although it is done as a part of the newborn screen that all babies have. But then we do some screening again later on, but I can't remember at what age. We do not add sodium and potassium to the fluids initially. With the potassium, we typically wait until the serum potassium comes down to 4 or less, and the sodium will wait several days to start sodium.
Okay, sir. The next question from Shivji Ramchandran. He's again congratulating you for your great presentation. And his question is, how early you start passive movements in these babies?
We don't do this for quite some time. We have physical therapists who work in the unit, and so it's not until the babies are quite a bit older that we'll ask them to consult.
Dr.
Okay.
Dr. Anjali Raj is asking, do you advise prophylactic phototherapy? What's the cutoff at which you accept bilirubin values or start phototherapy?
We do not use prophylactic phototherapy. We do have a protocol, and I can't remember the starting point, but it's similar to the more aggressive phototherapy group in the Morris report from the New England Journal that was a randomized clinical trial from the NICHD Neonatal Research Network, published in 2010 in the New England Journal.
Yeah. So moving on to the next question, the definition for significant PDA. Is it the same for preterm babies or there is some other criteria? He's asking. For significant PDA, hemodynamic.
Yeah, Professor McNamara has published papers about this, and he has a set of a scoring set of scoring criteria that we use, but it's basically the same as for more mature babies, and it's based more on flow than on the size of any of the particular measurements.
Yeah. So the next question from Dr. Nargis, do you perform DCC or delayed cord clamping? She's asking about with intact cord resuscitation in these micropremies. Delayed cord clamping.
Yes.
You recommend that or you practice that in your unit?
We try to, but it's not always possible because there is a certain level of anxiety to get the resuscitation started. We do not do cord milking, but some of these babies, we are able to delay the cord clamping for 30 seconds.
Yeah. And what about ROP screening? At what weeks you start screening for ROP in such micropremies?
It's according to the recommendations of the American Academy of Pediatrics and the American Academy of Ophthalmology. It's I think 31 weeks post-menstrual age, more or less. So it's not particularly early.
Okay, it is not about the chronological age, but the post-menstrual age of 31 weeks.
Yeah, I think that's right.
Dr. Madhumala is asking, during antibiotic treatment in these babies, do you routinely give vitamin K, and how, IM or IV?
No, we don't give vitamin K, but we do give oral nystatin when they're receiving systemic antibiotics. And we also routinely give fluconazole for the first 2 weeks.
Do you do GRV check prior to every feed?
Yes.
Okay. So it is the GRV should be done, or abdominal girth is to be measured. There are some recommendations that girth is to be measured.
No, we don't measure girth.
Okay. The next question.
Yeah.
Next question: how frequently you do blood gas if infant is only an HFJV? Jet ventilation.
It depends on the baby. It doesn't depend on the ventilator. Some babies on high frequency jet ventilation only need blood gases twice a week. Some need them every hour.
Okay.
Yeah, it was the requirement and clinical situations. Okay, so the next question: do you routinely start an oral antifungal regimen like nystatin when these small babies have central lines for the risk of invasive fungal infection? Routine antifungal that is like nystatin.
All the 22 and 23 week babies get fluconazole for the first 2 weeks, and all babies in our unit, regardless of gestational age, get oral nystatin if they're on systemic antibiotics.
Okay, so that is for oral.
The fluconazole is IV.
IV.
Nystatin is oral.
Nystatin oral.
So the next question from Dr. Madhu. Which frequency of feeding is good for these babies, 2 hourly or 3 hourly? But we have already discussed, I think.
Yeah, we give 3 hourly. 2 hourly would be good, but it's more work for the nurses.
Yeah. So even there are enough evidence for 3 hourly feeding for preterm also, other preterms.
Yes.
Okay. Dr.
Next
Nargis.
is very...
Yeah.
interesting question. Do you prefer milk infusion or gavage feeding in these babies?
We prefer gavage feeding, and most babies can tolerate this. Occasionally, we have a baby that needs to get the feeding given more slowly, and many of the 22 and 23 week babies will actually give the feeding every 3 hours, but will infuse it over 1 hour just because they don't like to have their stomachs distended.
And how frequently you measure blood pressure, blood glucose in such tiny babies? Monitoring of blood pressure and blood glucose.
Well, it depends. Initially, the blood pressure may need to be measured every, well, if they have an arterial catheter in, it's measured continuously, but if not, it may be measured every 3 hours. Later on, every 8 hours. The blood glucose, it depends on the baby, but in the beginning, every few hours, and eventually we don't need to measure it at all. So it depends on the situation.
Okay, but do you routinely use an arterial line for such tiny babies?
Yes, we usually will place an umbilical artery.
Umbilical arterial line.
Both umbilical artery and vein, and we will we'll place a percutaneous intervein catheter by the end of the first week and get the umbilical vein catheter out. The umbilical artery catheter will come out usually by the end of the second week.
Okay.
I think with enteral feeding, the blood glucose measurement must have been decreasing as compared to the IV fluids. And Dr. Bell, with enteral, monitoring of blood glucose decreases significantly once the baby is tolerating enteral feeding. The last question, I suppose.
Yeah, once the glucose is stable, then we don't need to check it as often.
Yes, okay. Thank you. I think.
One question is there, do you have a support team for your unit for NEAT cap care for this extremely preterm?
We don't have a formal NIT cap, but we have equivalent types of support.
Okay.
I think this is the last question, I suppose.
Yeah.
Yeah, Dr. Nargis, do you routinely perform PT with INR, and what is the policy for transfusing fresh frozen plasma?
We don't have a policy, and it's very rare that we need to use FFP.
Yeah. So thank you, Professor Bell. You very
really answered so many questions.
So many questions and so many queries. Really, those queries were also interesting because we are talking about the micro preemies now, not only preterm but micro preemies. So thanks for your answer, and patiently you answered all the questions. Thank you very much. Over to Dr. Manoj.
This was a very amazing session in both in its content and its length. This is one of the longest sessions we have had. We have had 2 or 3 sessions longer than this, but majority of the time, the questions today were, as Dr. Pradeep was saying, so relevant, and then by people who really want to know. So that is something, and Professor Bell, actually we are so humbled to actually have you and then wait for us for so long, despite I know that you are busy and then you are having other problems at hand, and leaving everything, you have been, you are cared to spend the time with us. So from the bottom of my heart, and on behalf of all of us, team Learn from the Legends, we would like to thank you so much for joining us today. As I was mentioning yesterday, looking forward to hosting you in person in the future in India, sir.
Yes.
It was my pleasure. Thank you for inviting me. I enjoyed our discussion.
Thank you, sir. I would also like I would also like to thank both the moderators, Dr. Josna and Dr. Pradeep. They had been doing a wonderful job. We really had they had patiently taken all the questions, and then they were, conducting the session so well. Thank you so much, Madam and Sir.
Thank you. Thank
My
you.
pleasure, sir.
Thank
My
you.
pleasure.
My pleasure, and thank you for inviting. Thank you.
Thank you. And finally, I would like to thank all of you,
For having
respected
such
attendees.
interactive session.
We have had, our total number of registration now stands at 9,300, and then probably the time frames are different. And so it's such a honor to have all of you, and these sessions will be available for you to watch in your comfort, in your comfortable time zones. With that, we close today's session. Looking forward to the details of the next session will be announced soon, and looking forward to seeing you in the next session. Thank you so much. Thank you
Thank
so
you
much.
so
Prof.
much. Thanks. Thanks.
Thank you. Thank you, Dr.
Thank you.
Pradeep. Thank
Thank
you.
you so much.
Thank you.